Hi friends, today we are going to learn inpatient coding MSDRG basics. Among all coding specialties, inpatient coding is very difficult to understand as inpatient coding is totally depends on MSDRGs or apr-drgs. In this session, we have tried to provide some important concept related to inpatient coding. So what is IPPS? IPPS means Inpatient Prospective Payment System. So using this IPPS, each case is categorized into a diagnosis related group. Each DRG has a payment rate and which is based on the average resources used to treat Medicare patients in the DRG. Usually IPPS is used for Medicare Part A claims. Next one, what is Medicare Severity Diagnosis related groups? So basically, MSDRG is a statistical system of classifying any inpatient stay into groups for the purpose of payment. So basically, MSDRG is a statistical system and which will classify each inpatient stay into groups for the purpose of payment. DRGs are assigned by a grouper program based on ICD-10 diagnosis, procedures, age, sex, discharge status, and the presence of complications or comorbidities. All these definitions we are going to learn as follows. So when do we get the IPPS annual updates? So basically CMS publishes updates or changes in the Federal Register in August of each year. So the changes become effective October 1st of each year. So now we will learn structure of MSDRG system. So basically MSDRG system is classified into major diagnostic category. Usually we will call it as MDC. Again each MDC has surgical DRGs and medical DRGs. In order to code surgical DRGs, we will use ICD-10 PCS codes. For the diagnosis or medical DRGs, we will use ICD-10 CM diagnosis codes. So now we will learn what is MDC. MDC means major diagnostic category. Basically, all diagnoses will be grouped into MDCs. So each MDC is a classification system of diagnosis grouped by body system such as circulatory, neurological, respiratory, digestive. Again, each MDC divides into surgical DRG and medical DRG, which is based on the presence or absence of a surgical procedures or any type of intervention, which impacts the reimbursement. So basically, these MSDRGs group similar resource consumption. So the conditions which will utilize the same resources or same resources consumption comes under same MSDRG. Total we have 25 MDCs. MDC 1 to MDC 23 are grouped according to principal diagnosis and body system. MDC 24 represents multiple significant trauma. This MDC is assigned when at least two significant trauma codes from different body site categories are present. So MDC 24 is for significant trauma which needs to have two significant trauma diagnosis from different body site. So we have MDC 25 which is HIV infections. In order to code MDC 25, the HIV infection must be a principal diagnosis or any type of HIV related condition or a secondary diagnosis of an HIV infection. And also we have two MDCs, MDC 0 and MDC 26, which are primarily related to specific surgical procedures. Next, what are pre-MDCs? So pre-MDCs are made up of transplant and tracheostomy DRGs. So if you see here, this is CMS website. It is version 40 So if we see here, we have all these MDCs. So nearly 26, 1 to 25 and pre-MDCs. So MDC1 is for disorder of nervous system, second is for eye, third is for nose, mouth and throat as follows. So if you click on pre-MDC here, you can see this document. Here all the transplants are included. You see here CAR T cell and other immunotherapies, heart transplant and tracheostomy with a liver or intestinal transplant, allogenic bone marrow transplant, lung transplants, pancreas and kidney transplant, autologous bone marrow transplants. So pre-MDCs are for transplants. So these conditions we need to use DRG 18. So in order to understand MSDRG, we need to understand few definitions which we are going to learn now. So what is principal diagnosis? So principal diagnosis indicates that a specific set of principal diagnoses are used in the definition of the MSDRG. So under UHDDS definition, principal diagnosis is the condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital for care. So here we need to understand after study, whatever the condition which needs to be established after study by the physician, then only we will consider as principal diagnosis. So what are additional diagnoses? Conditions that affect patient care in terms of requiring clinical evaluation, therapeutic treatment, diagnostic procedures, or extended length of hospital stay, or increased nursing care under monitoring. So in order to consider additional or secondary diagnosis, the condition or physician needs to clinically evaluate the patient, or patient needs to have therapeutic treatment, or patient needs to have diagnostic procedures and also increased nursing care under monitoring. So based on UHDDS, usually we'll call it as Uniform Hospital Discharge Data Set, defines other diagnoses as all conditions that coexist at the time of admission, that develop subsequently, or that affect the treatment received and or the length of stay. So basically conditions coexist means at the time of admission patient needs to have these condition, and those condition needs to have separate clinical evaluation and therapeutic treatment. Diagnoses that relate to an earlier episode which have no bearing on the current hospital stay are to be excluded. So we need to understand that prior conditions we can't consider as secondary diagnosis. The conditions which present at the time of admission we can consider as secondary or other diagnoses. Next one, what is present and admission indicator? Usually we will call it as POA indicator. So a condition or conditions present at the time of the order for inpatient admission occurs. So in order to apply POA indicator, that condition or condition must and should needs to be present at the time of inpatient admission. The POA indicator is intended to differentiate condition present at the time of admission from those conditions that develop during the inpatient admission. So it will divide the conditions of the patient during the hospital stay. So POA indicators has some requirement which we will learn now. So POA indicator reporting is mandatory for all claims involving inpatient admissions. So in order to use POA indicator, we need to have or we need to apply to all claims involving inpatient admissions. Hospitals do not receive additional payment for cases in which one of several select secondary diagnoses referred to as hospital acquired conditions were not POA. So if the patient has a hospital acquired condition which is not POA, that means that condition is not present at the time of admission, hospital will not get the amount or payment. So basically, for hospital acquired conditions, hospital will not get the payment. So basically, POA is the conditions that develop during an outpatient encounter as considered PVA. For example, if you take ED, observation or outpatient surgery. So there is no required time frame as to when a condition can be identified as POA. So we can add POA at any time during the patient's hospital stay. So where do we apply POA indicator? So POA indicator must be assigned to principal diagnosis, secondary diagnosis, or and the external cause of injury codes when it is being reported as an other diagnosis. If the other diagnosis is the external cause codes or injury codes, we need to assign POA indicator. So issues related to inconsistence, missing, conflicting or unclear documentation must be resolved by the provider in order to assign POA indicators. So what is the POA indicator and what is the uses? So the purpose of POA repeater indicator is to differentiate between conditions present on admission and those conditions that develop during an inpatient admission. Usually we have four types of indicator, otherwise POA indicator: status Y, status N, status U and status W. So status Y means diagnosis was present at the time of inpatient admission. So status N means diagnosis was not present at the time of admission. Status U means documentation is insufficient to determine if the condition has POA or not. Next one is status W, which is clinically undetermined by the provider. So next we will let what are major complication or comorbidity MCC and complication or comorbidity conditions. So a comorbidity is a condition that existed before admission and a complication is any condition that occurred after an admission. So basically comorbidity is before admission, complication is after the admission. So the severity of the illness or condition is determined by the presence or absence of MCCs and CCs. So the severity of the condition will be determined by use of MCCs and CCs. So the presence of these will impact the DRG assignment and subsequent hospital payment. So basically, Medicare has identified certain diagnoses that consume additional resources for the hospitalized patients and therefore increase the reimbursement rate based on the associated relative weight when assigned as a secondary diagnosis. So whenever we will code CC-MCCs as a secondary diagnosis which will utilize the additional resources, DRG rate will be increases. So what are few examples of CCs? Bacteremia, hemiparesis, hematemesis, and acute renal failure and UTI, and also chronic systolic heart failure. So whenever you see the documentation using these conditions, you need to understand that these all comes under CCs. So what are the examples for MCCs? HIV, coma, cerebral edema, acute cerebral infarct and end-stage renal failure and so on. So whenever you see these type of condition, you need to understand that which is MCC condition, which will increase the DRG payment to the hospital. So we have basically four different categories of MSDRGs: single tier, two tier, three tier. So single tier means documentation of a CC or MCC does not impact reimbursement. Two tier or pair means for some two tier MSDRGs, reimbursement increases the same account with either a CC or MCC. For others, reimbursement only increases with an MCC. So for the two-tier conditions, reimbursement increases the same amount with either CC or MCC. So whether if the patient has CC or MCC, irrespective of that, reimbursement will increase. Three-tier or triplet, reimbursement increases with CC and is increased further with an MCC. Next one, what are DRG validation audits? So what is the use of or what is the purpose of DRG validation audits? So verification of the diagnostic code assignments, verification of the procedural code assignments, verification of present on admission indicator assignments, verification of the sequencing of codes, verification of the DRG grouping assignment and associated payment, so verification of the MCC and CC when reported. So these are the audits which will consider very important for DRG validation. So DRG validation audits may result in revisions to the diagnosis codes and the procedure codes. Obviously, if there is a change in the audits, we need to adjust those diagnosis or procedure codes. These revisions may result in a change in the DRG assignment. Next one, what is GM loss? So geometric mean length of stay, which is called as a value used to calculate reimbursement. What is AMLOS? Which is arithmetic length of stay, a value assigned to represent the average. So what is relative weight? A value used to calculate total payment for the case. So DRG groups with higher relative weights are paid more than those with lower relative weights. So obviously if the condition has higher relative weights, they will get more payment than the DRGs with lower relative weights. Next one is what are HACs? So HAC means hospital acquired conditions. So these HACs will increase high cost, high volume or both. So HACs will result in the assignment of a case to a DRG that has a higher payment when present as a secondary diagnosis, and also be reasonably preventable through the application of evidence-based guidelines. So what are the common HACs? Stage 3 and 4 pressure ulcers, falls and trauma, and manifestations of poor glycemic controls like diabetic complications, DVT, knee replacements, hip replacements, and surgical site infections which are commonly occurred during the stay or during the hospital admission. Next one, what are the common requirements for DRG assignment? So first we need to have principal diagnosis. Next we need to have secondary diagnosis, and we need to check whether any surgical procedures are performed or not, and we need to check whether any CCMCCs, we need to check patient's age and sex, we need to check discharge status. In order to code inpatient records and in order to get proper DRG assignment, we need to have all 6 criteria. So what is a grouper? A grouper is a software program designed to assign the DRG classification. So basically we no need to do any calculations. If we enter the conditions into the grouper, it will calculate automatically. Next one, what is case mix index? So the case mix index is the average MSDRG weight based on the specific patient group and is determined by multiplying the DRG weights by the number of patients and then divided by the number of patients. So basically it is the average of the MSDRG weight for the specific patient group. Usually we will call it as CMI. So a higher CMI should equate to treatment of sicker patient as the highest RVs were associated with surgical patients compared to medical patients, MSDRGs with MCCs compared to those with only a CC or without a CC or MCC. So as we have already learned, PVA indicator is indicator which usually call it as present on admission indicator, which will differentiate the condition which are present before the admission and after the admission into the hospital. So here we have two example scenarios. Using this we can understand easily. So here patient is a 22-month-old child, has pyelonephritis and dehydration, and both are equally treated with which MSDRG will have the highest weight. Usually, if we check the conditions, so pyelonephritis has a weight of 0.77 and dehydration has the weight of 0.70. So obviously pyelonephritis will be the PDX here and it will have the very high DRG weight, which is based on the coding guidelines. Two or more diagnoses that equally meet the definition for principal diagnosis. So if both are equally meets, we need to consider the condition which have the higher DRG weight. We have one more example. Here patient is a 65-year-old patient who has pneumonia and congestive heart failure, which MSDRG will have a higher weight. So if you consider the MSDRG or relative weights, pneumonia it is 0.70, whereas in congestive heart failure relative weight is 1.50. Obviously congestive heart failure will be the PDX here. So if the DRG is, so whenever we have multiple conditions, we need to check which has the relative weight more. Thank you guys. Thanks for watching Fast Coder 21. Please like, share and subscribe to our channel.